Oh, hey, Chris.
Hey Chuck, how are you?
I'm great. We're back at it.
Yes, we are. It's a weekend morning. We both have different backgrounds from our last episode, which is nice. It's nice to be at home.
Absolutely. It's funny. My wife is redoing her office and it is going to be a little more Zoom friendly. So prepare yourself for a new background.
Well, you always blur yourself anyway, so what does that
I,
matter?
that's somewhat new. I'm going to unblur myself when I have this spectacular background. It better be spectacular, but I'm
So
going to unblur.
I will say, this is the nerdiest thing, but if you look behind me, that's actually a watercolor of the brachial plexus,
Oh, God.
which I have not let anybody know that before in all the different times that I've Zoomed with people. But at one point, I can't remember who found it, but there is a Etsy shop with various artworks related to the brachial plexus.
That's hilarious. I thought maybe a patient did it. I thought maybe you did it. You were trying to expand your horizons and we're doing watercolors now on the weekend. Wouldn't put it
No,
past you.
no, no, no. We also have in our entryway, there's also a different form of the brachial plexus in a nice looking art piece, which is pretty cool. But I think we've met our maximum of brachial plexus related artwork at two.
I think you have.
So that's why I don't blur the background. I always hope somebody will pick up on that, but nobody ever does. I don't know why.
It kind of looks like a beach, or I don't know what with the sun. I guess we're not close enough.
So yeah,
Yeah,
those of you that are listening need to just go onto YouTube and check it out.
that's right. See if you recognize a brachioplexus. No, of course, if it, I wouldn't recognize a brachioplexus, even if I could see it clearly. So
Yeah, and that's a classic orthopedic approach to it, right? Just
yes,
in so many ways.
let it be blurred in my mind.
Oh man. So we're getting into part two of what's new in hand and wrist surgery. This is published in JBJS of at this point it says March 19, 2025 print issue, written by our friends Eric Wagner and Nina Sue. Before we jump in, we should acknowledge our friends at Practice Link.
Absolutely, we should. The Upper Hand is sponsored by PracticeLink.com, the most widely used physician job search and career advancement resource.
Becoming a physician is hard. Finding the right job doesn't have to be. Join Practice Link for free today at www.practicelink.com/the upper hand.
It's interesting. I've had a run of patients lately, which will lead me to a question that have had essentially failed decompressions done in the community. And I would say I've done five in the last month. And
Decompressions of the
I,
cubital
I,
tunnel.
thank you. I'm sorry. Yeah, decompressions of the ulnar nerve of the cubital tunnel, all done through a relatively, what I would say, long incision, not a mini incision. Preoperative workups, unclear, but all of them at least perch, if not subluxate, and all have continued symptoms. So my questions for you, and this is we'll get to the point of the question. Number one, some things I read say that 90% of initial treatment is now decompression. That sounds high to me, but you will know better. And two, what's your experience in the last 6 months been with treating failed decompressions?
So I guess the question is it truly failed? Like, did they actually get some temporary relief of symptoms? And as the literature would suggest, at least I quote 15% of people because I know the number that you and Dr. Mansky wrote was 7. The number that was reported by Ryan recently was 20, and there's probably somewhere in between. I say 10 to 50% chance of needing a second surgery at some point. So is it failed? Like they actually just didn't get better right away. Maybe it was a wrong diagnosis, or something the nerve was completely destabilized, et cetera. Or did they have a couple of years of relief,
Yeah,
and then they ended up needing something else done in the future? I don't
yeah,
know if that would be called a failed surgery because you kind of told them they might need another one.
right. And obviously, I have no idea what was told to them. These were all within 6 to 9 months of their original surgery without any significant relief, but classic cubital tunnel symptoms. Um, and not just local symptoms, symptoms radiating. So to me, it's just a failed surgery.
Yeah, so I mean, I think that your question about how often people are doing decompressions relative to transpositions, that number feels high, but it doesn't feel absurdly high based on at least the administrative data studies that were done. I think about 5 to 10 years ago. It's because I think the way that a lot of people interpret the literature is that there's no difference in outcomes between transposing the nerve versus purely decompressing it. That being said, I think the literature upon that is based is flawed in terms of methodology. And then there's some bias, I think, in terms of where that literature is published. I think a lot of that was published in the neurosurgery literature and then is subsequently disseminated. And this is not a knock on our neurosurgery colleagues, but I think they are less apt to do a transposition because it's less in their wheelhouse than a hand surgeon or, an orthopedic surgeon or a plastic surgeon. Um, that's my suspicion. But then this sentiment has creeped out into the literature and gone on to payers that there's no difference between the two. And then I think that's the reason ultimately why we don't have a separate code for a transposition, unless, depending on how you separate out your procedures, you could get an additional code for the Z lengthening or for the adipofascial flap or whatever you're doing. But if you were to purely code it, there is no difference. And there is definitely a difference in the work done. So in the setting of perceived equipoise between the two procedures or equivalent results, that's probably a better way to say it, and no difference in compensation, an American surgeon is most likely just to decompress the nerve.
Oh, it's so true, and the importance of the neurosurgery literature in affecting this comparison is unbelievable, and they really have just dramatically, it has continued. I remember when there was only four articles when Dr. Mansky and I shared our experience. There were literally four articles, and three of them were neurosurgery, and obviously things have changed. But interesting. And so, getting to back to our review, which highlights that, people choose subcutaneous or submuscular and no dramatic difference. Do you always go submuscular with a revision treatment of an ulnar nerve?
Yeah, so I mean, I think that it kind of depends on what's been done before, and I think the important part is, at least when I stress to our trainees, is that you have to know how to do both. You have to know how to do all sorts of things because you never know what you're going to find. Um, Something that was supposedly subcutaneous may not actually be subcutaneous, and vice versa. So, being able to think on your feet, preparing yourself appropriately, and counseling the patient appropriately, is super helpful. I tend to go submuscular for revisions, mainly because, as this review shows, that a submuscular is most likely, compared to a subcutaneous, to have a more reliable improvement of symptoms. Because it is, in my opinion, and I think many, the most definitive surgery, but you pay a price for it. It's a big surgery with a longer recovery, and there are additional risks that come with it, specifically hematoma formation, worsening pain, and some perception potentially of weakness after you have divided the flexor pronator mass. But this was a meta-analysis, so 20 studies, 471 patients. I didn't personally read that article yet, and any meta-analysis is prone to, the weakness of the literature that's put into it. The so-called rubbish in, rubbish out, or garbage in, garbage out. So I don't know how rigorously this was done. There's a lot of sources of heterogeneity and bias, and when you put all those papers in, and if you don't have great level of evidence, you're not going to get a great meta-analysis.
Yeah, I will say one thing that's really interesting to me, and I'll clarify this for our foreign listeners, international listeners. In the United States, we're paid essentially based on what's called RVUs, work effort, which I think is international to some degree, but not exactly in the U.S. system.
Relative value units.
Thank you. So for a carpal tunnel release, which all of us would probably agree should be 8 to 10 minutes, sometimes it takes longer. It's 5.4 RVUs. And a 64718, which is the CPT for cubital tunnel decompression or ulnar nerve transposition, is 7.93. So the difference is stunningly little, at least in my mind, because the work effort is dramatically different.
Right, and it's interesting because these RVUs are supposed to reflect the intensity of the labor performed, and at the end of the day, some are going to be undervalued, some are going to be overvalued, and then as surgeons and practices evolve and get better at things and quicker at things, maybe something doesn't take as much time, and that relative value unit gets reassessed and moved up and down. Are you seeing that, for example, in hip and knee arthroplasty? Where hip and knee arthroplasty is a fraction of what it used to be in terms of RVUs, but in part it's because we've gotten so good at them and so efficient at them. So you can see both sides of the coin there.
For sure. For sure. All right. I know you want to just talk about nerve for the rest of the pod, but we do have some other topics to cover.
We do. So distal radius is the next area that Eric and Nina got into, and they go to an osteotomy first. But I actually think it'd be more appropriate to talk more about fracture management first, and then go back to osteotomy. So, they looked at age and radiographic factors, which I thought that we had settled this question, but we keep looking at it, and they go into a couple of different studies demonstrating, how much sagittal alignment displacement is appropriate or acceptable, et cetera. I mean, at the end of the day, like where are you at right now in terms of how much dorsal tilt you accept, and does it depend on the age of the patient? Because that's what they seem to be driving home here.
Yeah, I agree. That's what they're driving home. And I mean, one of the papers is a stunning number. In a recent study of 366 patients, dorsal tilt of more than 5 degrees was found to be the strongest factor correlating with worsening clinical outcome, excepting for patients over 75 years of age. Um, and yeah, I think we all have come to I think the consensus that older patients are treated differently. Number one, what does older mean? And number two, how much is too much? There's the orthopedic surgeon in me has trouble when we get too high. Like if we're above 20 degrees dorsal tilt as the primary indicator, I will at least try a close reduction. I don't think I can just close my eyes and hope that does well. I will talk
Regardless
about
of
it.
age.
I mean, not completely regardless of age, but if it's a healthy 75-year-old or healthy 80-year-old who's active and it's 25 degrees of dorsal tilt, I will absolutely have the conversation, but maybe with a bent towards at least a closed reduction impending.
Is a close reduction, for lack of a better term, is it palliative? Like you're just trying to get it back in the ballpark and then you can treat it in a cast? I mean, so you said close reduction and pinning. I didn't know whether you meant close reduction potentially and just splinting slash casting.
I like closed reduction in the office if I see the patient within 3 days. It has to be the right patient. They
Three
have to
days.
three
That's
days, which happens,
It's
but
not
not
going to
as
help your
much.
patient satisfaction scores.
It might if it keeps them out of the OR. But no, it's a tough topic, and it very much this is the art of what we do, and it's conversation based. But I think it's a dangerous kind of perspective to just say everyone over 75 years of age will take whatever. I don't think anyone's saying that, but I do think we
I
have to
think
have a
some people are
conversation.
saying that.
Well, you may
Um,
be right.
But I based on, I mean, you can, I when we talk about when we do journal clubs, et cetera, I always tell our learners, you can, depending on your bias, you can always find data to support your narrative. So you can pick your papers that you say, all right, this is what this shows. It's just like that in any field, whether it's just a radius or a nerve. Like we had a nerve journal club the other night with plastics and neurosurgery, and we talked all about our biases, and you can always find something that supports what you want to do.
Yeah.
Anyway, so interesting anecdote actually come dovetails with this perfectly. I was in the OR on this past week, and I got a text from our one of our physiatry colleagues who was running the orthopedic injury clinic. Just a very, very dorsally displaced distal radius fracture, almost in a different zip code, but in an 85-year-old. And I said, well, if you can, if you're up for it, let's do a closed reduction under a hematoma block because I would love to see if we can just get it in better alignment. Not assuming it's going to continue, it's going to redisplace some, but if we can get it in a better position and splinter there, that might be good for pain control. So, and I love it when it works out. I went over, did a hematoma block, did a closed reduction in the office. It worked out great. I'll see her back and see how much she's displaced, but at least we gave it a try to get it in a better position. But that being said, I think that while I look at this tilt, I'm not sure how much of the tilt matters. I like the McQueen papers that demonstrate kind of the alignment of the carpus in the hand relative to the radial shaft extended because I think that that is probably more useful to demonstrate to people rather than measuring angles. Say, look, the ice cream's off the cone. Can we get the ice cream back more on the cone? And if you're closer, then I think you have a better chance because, those McQueen papers demonstrated when you have dorsal displacement of the carpus relative to the radial shaft extended, you've got worsening grip strength. Your dash scores are worse. And I think that's, I have not seen enough in the literature recently that has changed my thinking on that.
I think that's really well said. The this is a topic which is of you know strong interest to hand surgeons, general orthopedic surgeons, people who dabble in general orthopedics. So it is a really important topic, and the volume obviously exceeds much of what we do compared to other clinical diagnoses. But this is going to be incremental progress as we're seeing. There's not going to be a study that answers the question, so it will remain interpretive as far as what you choose to do, what I choose to do, using the best evidence that we choose to recognize.
And I do think the pendulum has swung in both directions and is now kind of settling somewhere in the middle. And I think the literature, as it's evolved, I mean, people ask, oh, why do we keep studying this? It actually, I think it is kind of narrowing down and getting appropriate. I mean, I would agree that you do have, in a different paper that they mentioned here, you have diminishing benefit of surgery with patients over 80 years old. And it is diminishing. Doesn't mean there aren't people that will benefit from it because there are, 80 but physiologically 65, and then there's 80 but physiologically, much older. So I do think there is still a role for surgery in that population, but it's the indications I think are getting much narrower, and it does have implications of we talked about RVUs. I mean, do you know off the top of your head how many RVUs a volar plate implantation is?
No, but I can tell you in a very quick second.
I want to say it's like up high somewhere between 15 to 20. Which, for the amount of work that actually goes into doing most of these straightforward fractures, I think that might be relatively overvalued at this point. But the volume of patients that you operate on can change substantially based on your interpretation of the literature.
Yeah, and it's obviously we hope that people don't look at RVUs for a procedure to determine whether to do it or not. But let's call it what it is. 25607, which is an extra-articular Achilles fracture, typically is 9.6 RVUs, a two-part intra-articular 11 RVUs, and a three-part 14.4.
So I was a little bit off, but it's honestly like how long would it take you to do a Colles versus a an ulnar nerve transposition? You think
Yeah.
about relative value.
Yeah, that's it. It's a really good point. The other article which they cite, which caught my eye, was regarding quote, low overall complication rate of 12.3%. Now, most of those complications were minor, but that included 2.7% implant removal. And that's a whole nother conversation because we've
Hmm.
talked about international differences in that regard and a 1.9% rate of carpal tunnel surgery. Um, one of the things I've been emphasizing to our trainees, which maybe I should have been doing it 5 years ago, is not accepting neutral tilt with a volar plate.
Yep.
We
Yep.
have to restore volar tilt, or else the plate is going to cause problems, or at least have a higher chance of.
Yeah, I know we've talked about this before on the pod, but like, the volar plate, as described by Dr. Orbe when he came on the pod, was designed to fix an anatomically reduced fracture. So if the traditional, at least orthopedic literature for distal radius fractures talks about what you can accept in terms of sagittal alignment, and an acceptable reduction, does include some elements of dorsal tilt, usually less than 10 degrees. But that is no longer acceptable in the context of putting in a plate, because now you have a different issue with the plate potentially becoming prominent and irritating tendons, and leading to this implant removal rate of supposedly 2.3%, 2.7%. Does that number feel right to you? I mean, I actually quote patients just a rough number because it sounds real enough, but it's not huge, of 5%. Of implant removal, at least in my practice, and I think that feels right. I don't take out a lot of these. I don't fix a ton of them. I fix the ones that I think are appropriate, but about 5% feels right to me.
Yeah, my volume, interestingly, is certainly not what it used to be. I probably fix 25 a year, and that's not a surgeon number. That's a real number because I just looked. So
Yes,
that's
we get our quality report or our cost reports.
yes, exactly. I quote 5 to 10%, but I think 5% probably is the right number. I discuss it with everyone, but I think 5% is the right number.
What's your carpal tunnel syndrome rate here, you think?
Compared to the 2 point whatever
Yeah.
or 1 point, what was it? It was, I'll edit this out. Compared to the 1.9% cited in this study, first of all, I think I'm not aggressive in doing a carpal tunnel release at the time of surgery, and that's not what this 1.9% is. But if there are any indications of tingling or altered sensation, I absolutely do a carpal tunnel, and I think that's the right approach. If there are no signs, even if you're doing a bigger surgery, I don't usually do it as opposed to I think Marty Boyer, one of our partners, does. I think as a secondary surgery, 1%, 2% probably feels right. What about you?
I think that feels about right. I know other literature suggests that it's higher, but I can't remember whether that other literature is in the context of plate fixation or whether it's in the context in just any fracture, like all comers. Because I do think as you accept more dorsally displaced fractures and more of an expected malunion, um, you are going to get more patients because of the dorsal tilt and the increased pressure on the median nerve at the level of the malunion. You will get more patients that have symptoms. And I've done, I can remember right off the top of my head, a handful within the last year of patients in which we've accepted their malunion, but they develop carpal tunnel symptoms and we go on to do a carpal tunnel release. So that's something I counsel about from the beginning as part of the non-op conversation. I think that the 2%, here probably feels about right in the setting of a volar plate. But again, like I'm somewhere between you and Marty in terms of aggressiveness of doing a carpal tunnel release for some of this in the fracture setting.
Yeah, totally agree. Totally agree. All right. Let's jump to arthroplasty. There's a nice section, and I recommend reading it on PIP and MP joint arthroplasty, and then there's a whole nother section on basal joint. I think my takeaways are that while pyrocarbon and other implants are continue to be an option, silicone probably remains the gold standard for the PIP joint and the MP joint, although that may change over time. And certainly there are centers and individuals who believe in the pyrocarbon implants. Do you have a different interpretation?
No, I think, this is, I think that it's limited to the centers that have experience. There's nothing in the literature right now that's going to compel me to say that pyrocarbon is appropriate more than silicone until it's more broadly disseminated. And again, I don't do a lot of, I really don't do these, to be honest with you, because I send them to Marty because Marty loves doing them. And, I probably need to start to do more of them as, we look at some point, whenever Marty doesn't want to practice anymore in like 10, 15 years or something like that. So,
Yeah, it's funny. Someone will have to step into that void, but I do the same thing. I used to do them. I don't do them anymore. Getting back to our last episode when we talked about how fortunate we are to have partners with real strong interest. The CMC joint you and I have talked about a lot. The review presented here doesn't really differ from our previous conversations. I think the high level is number one, there's lots of options
hmm.
interventionally when non-operative care fails. And number two, implant arthroplasty is absolutely growing worldwide, but slower to grow in the United States.
Yeah, I think this is you've got such a reliable surgery that is ingrained in so many hand surgeons' minds as being the gold standard that it's going to be hard to beat it with an implant. Because even among, I think the experience with the implants was so poor early on in the United States that it was just taught to so many US surgeons that, don't ever put anything in there.
Yeah, no, that's exactly right. Anything else on arthroplasty you want to call out?
No, I'm just not excited because I've got to take one of these implant arthroplasties out coming up soon. It's
Oh,
not going to be fun.
oh goodness, I don't recall ever doing that. So good for you.
The chief resident I'm working with now is actually going into arthroplasty. I told her we don't have a Midas available, but I'm gonna need you for this one. So
That's
get all your
exactly
tips
right.
and tricks ready. I'll find a Dremel or something.
Yeah,
Before we go on to our next session, your favorite topic, wrist arthroscopy, we should shout out our friends over at Checkpoint Surgical.
yeah, we definitely should. The Upper Hand is sponsored by Checkpoint Surgical, a provider of innovative solutions for peripheral nerve surgery. As a hand surgeon, you know that nerves matter. Even hand surgeons like me know that nerves matter. It's why Checkpoint Surgical is singularly focused on elevating the clinical practice of peripheral nerve surgery with innovative technologies that help improve patient outcomes.
Checkpoint Surgical's portfolio includes a range of handheld intraoperative nerve stimulators, nerve cutting instruments, and biomaterials. To learn more, visit www.checkpointsurgical.com. Checkpoint Surgical, driving innovation in nerve surgery.
So our friend Eric Wagner is an arthroscopist, and I'm shocked and disappointed that there's only
Two
two
paragraphs,
two
two
pair,
paragraphs.
which don't even really, no offense to the literature and no offense to Eric and Nina, don't really say a whole lot. There's so much going on in the world of arthroscopy, but to be true to this, not much to say. Arthroscopy internationally
hmm
is really growing and is important. In the United States, I think it's slower, just like implant arthroplasty. Wrist arthroscopy is slower to dramatically evolve and slower to grow in the number of procedures done, but it is.
He picked an article that, demonstrates why I will never be an expert in arthroscopy. Uh, why the hell would you do a four corner fusion through arthroscopy? It just makes no sense to me. It sounds
As
awful.
as an arthroscopist, I would not. And I'll never forget when our Philadelphia friends were doing PRCs through the scope. And for me, it's not a can you, it's a should you. And for me, those kind of things don't make sense.
Is there an actual potential benefit for doing an arthrodesis under the scope?
I mean, you can aggressively remove cartilage and decorticate bone to obtain a fusion with a burr. And when the just I don't love doing that for the lunate. When I'm doing a four corner fusion, which I don't do many anymore, but that's my least favorite part of the procedure. And I think doing it arthroscopically, in some ways, probably would be easier. But no, there's no indication for me to do that.
All right. Then the other article to talk about for scopes is, low fidelity training models. Do you think that, a low fidelity model is actually going to be that useful in terms of developing the wrist arthroscopy skills, as opposed to knee or shoulder?
Yeah, what I preach is that I do not believe the technical performance of wrist arthroscopy is all that challenging. It's not an elbow. The challenge is identifying pathology, and I think that's a real challenge. So we need to educate better and doing the procedures. There's nothing particularly challenging about doing the procedures. It's identifying pathology.
Okay. Can we zoom to my topic of interest, peripheral nerve?
Oh God, I thought we already talked about it, didn't we?
No, we didn't. We didn't get there yet. So they shout out an interesting article on the ongoing dilemma, or I guess conundrum about whether to do nerve transfers, tendon transfers for radial nerve injuries. And I think the article they shouted out here said the tendon transfers were found to have the highest percentage of good outcomes, 82%, with the lowest percentage of poor outcomes when comparing to nerve grafts and nerve transfers. Which, honestly, to be fair, those are two different beasts, grafts and transfers, in 754 patients. Um, I will say I think the radial nerve tendon transfers good outcomes, meaning just good, are pretty reliable. And poor outcomes are uncommon. But I think a lot of that is driven by the discussion you have with the patient.
For sure. And I would say, I increasingly debate whether my good, and I think that's the right descriptor, outcome of tendon transfers and radial nerve is the best example, are better than my sending the patient to you for nerve transfers. And I think there's so many variables that go into that. But I think that's a good summary.
When the nerve transfers in the right patient, the nerve transfers can be an absolute home run, but it obviously takes the right patient who has the right amount of patience in terms of waiting to get that done. And some people don't want to wait. And I still like doing tendon transfers for a lot of these patients. I think that it's helpful to allow them to move on because I think a lot of the psychology of a nerve injury is when can I move on from this and just kind of, get back to work, et cetera. And depending on what they want to do, for a lot of people, tendon transfers are the right answer.
No, that's exactly right. And yeah, I think we'll continue to learn more about outcomes and timing of improvement and all those kind of things. But yeah, I think this is a small step forward.
So keeping in line with our discussion about RVUs, it's a nice study from Michigan showing that after the introduction of a CPT code, in which the RVUs are assigned to, for nerve allograft for small gaps, guess what? People started doing it more, and use of conduits declined. So I think that's a really interesting, insight into how things work here, at least in the States, is that when you get the holy trinity of innovation is that it works, and people use it more, and people get paid to use it, and so that's why you see so many companies try to get CPT codes for their different adjuncts and different procedures.
Yeah, that's exactly right. It is a nice adjunct to what we were talking about, but you're right. It has to have a CPT or else it just doesn't move the needle.
Yeah, and they noted that at least at the time of this paper, the use of allograft for gaps over 4 centimeters did not increase. Thank goodness, because and I think that there's probably a shift that's starting to occur because there are more papers demonstrating that allograft, at least in the minds of those who write the papers, I'm going to put it very carefully, demonstrates acceptable outcomes. Um, and I think this is a line we're going to have to walk very carefully because I think there are more papers coming out showing that allograft is acceptable in more situations. And that's not my personal preference, but more people are going to say that the literature reflects that. And I think we're going to get into an issue with allografts being used more frequently
Yeah,
for large gaps, and to be very clear, for mixed and motor, which again I don't personally agree with, but that's a whole different topic.
yeah. And as we bring this episode to a close, there's some discussion on some common things, I would say, without dramatic new findings, including de Quervain's trigger finger. and slack wrist treated with either PRC or four corner fusion, going back to what we previously say. I don't think there's no novel findings to share. I did like there was a trigger finger study that looked at 114 patients with repeated injections and followed for 12 months. Um, and they found overall success rate from repeated injections decreased from essentially perfect results at 1 month to 50% or 49.1 to be exact at 12 months. So interesting. And there were other risk factors discussed as well.
I like it because it gives me a number to use. Because one of the questions I get a lot is, how long is this going to last me? And I kind of hedge and I say everybody's a little bit different. But now I can say there's probably a 50-50 chance this will come back in a year.
Yeah, that's exactly right. And I actually have been quoting 40. So, hey, and again, there's so many variables with diabetes, et cetera. But, this exercise and you and I need to go back and reread some of the articles. It's really helpful for me. So I appreciate Nina and Eric working on this. And I think it's a real contribution and definitely recommend reading the actual article for those of you who have the time and inclination.
Yeah, I mean, it's always it's fun to do, and it does point out kind of what we need to learn still. And I have circled a few of these to go back and read the primary article. So yeah, thank you, Nina and Eric, for doing it. So we're getting to the point where we're podcasting into the summer, and if anybody has any topics they want us to discuss, feel free to email us handpodcast@gmail.com or leave it in a 5-star review on your iTunes or Spotify.
Absolutely. All right. It's been fun. Thank you.
All right.